Hello and welcome to another Can Do MS webinar. My name is Krista Sipp and I'm the Director of Programs here at Can Do. I will be your moderator this evening. Our topic tonight is hormonal health and MS, a guide for both men and women. Thank you for joining us tonight. And we are very excited to partner with the Texas MS Consortium to offer two special webinars this month. We're thankful for their partnership and the exciting projects that we're working on together. If you are here and you don't live in Texas, don't worry, the information tonight is still relevant to all those affected by MS. So thank you all for joining us. I also want to take a moment to thank our sponsors tonight. Thank you to the generous support of the Kathleen C. Moore Foundation. Thank you to Genentech, and thank you to Novartis for their support in making this program tonight possible. I have the honor of introducing our speakers this evening. So welcome to Dr. Leora Freeman, who's a neurologist, and welcome to Dr. Alexandra Rossi, who's a nurse practitioner. Both of them are out of Austin, Texas at UT Health. Thank you, ladies, so much for being here tonight and for sharing all of the information we're about to learn on hormonal health and MS.
It's such a pleasure to be here tonight. Thank you for Can Do MS for bringing us all together. We're very excited to have a really engaging conversation with you all about hormones and MS. Alexandra and I are super passionate about it, and we're really excited to tell you more. And so that brings me to our learning objectives today, which is to kind of understand what's the role of hormones is in our bodies and how it can affect and interact our immune and nervous systems. Second is to recognize signs and imbalance that can impact MS and your quality of life. And then finally, to explore options for managing different hormonal changes through lifestyle, medical treatments, and collaborate with your healthcare provider. Next slide. So we'll wanted to start with a couple questions to kind of have an understanding of where you hormones. And first is a simple question, like, have you ever wondered whether your hormones were impacting your MS? Simple yes or no. Go ahead. And yes, overwhelmingly yes. So that doesn't surprise me at all. We see more and more people asking questions about hormones in our clinic. Our next question is I wanted to understand a little bit more like what really is a concern for you? Is it problems with your thyroid, puberty, fertility, pregnancy, menopause, andropause, stress response, or other? Write it in the chat. So we'll give you a few if to complete this survey. Already seeing some things in the chat too. Menopause, a big one, I agree. And stress response, kind of close second. So I'm glad we added a little section to talk about this today. And thyroid as well. So some diversity of issues to talk about. So let's move on quick to the next slide. We have a packed agenda. Whoop, this one. So first, I think that all of you know to some degree what hormones are, but they're a little messenger within our body. They're chemical messengers and they really regulate a ton of body functions. Depending on the hormone, they can be produced somewhere, whether it's a thyroid, whether it is our genital organs, whether it is the adrenal gland, and then they travel via the bloodstream to all kind of different organs and tissue. And they can affect, our metabolism, our mood, the sexual function, sleep, cognition. So they really play a pivotal role in how our body works. We'll talk today about different kinds of hormones. We're going to talk about thyroid, estrogen, testosterone, cortisol. We're not going to talk about insulin. That could be an entire other talk, but we're going to try to cover as much as possible about different hormones today. I see what is sleep in the chat, and I can totally relate to that. What is sleep? Alex and I have 9 children between the two of us, and I think that has eluded it for quite some time. Why do we talk about hormones in MS? First, because hormones can influence inflammation, and all of you know that inflammation is a key, process in multiple sclerosis. And through this role, through the immune system, and also interacting with the brain, it can impact different functions. And MS, we'll see, can be affected. The course of MS can be affected by different hormonal states. And even if it's not completely changing the course of the disease, we can see some worsening or improvements of symptoms during that time. We'll see that some MS treatment can influence also some hormones and the production of some hormones. We're going to talk a little bit about that today. But we will also wanted to have this seminar because we feel that this is not something that people talk a lot about. And to answer a question in the chat, what is andropause? This is basically the menopause. So, while we suffer, really harshly during menopause, men also experience some changes with age and the decline of their testosterone that we call andropause. And we're going to talk about this today because we don't want to forget our men. So let's go to the next slide. So how, hormones can influence MS because hormones talk to the immune system. So as you know, the immune system is your body's defense team. It's what helps you protect against infections, help heal injury, keep you healthy in general. But the immune system is also what acts up in the context of multiple sclerosis. Hormones are helping guide, the team of your immune system, and that they can even sometimes tell your immune system to work harder. They can tell your immune system to calm down, and different hormones have play different roles, and that can explain how they kind of work differently in MS. So for instance, estrogen help kind of the immune system work more strongly, while testosterone and progesterone can tell the immune system to quiet down. Cortisol, which we sometimes call the stress hormone, and we'll see how this may not be the best name for it later today, helps kind of also control inflammation, but its role will depend of like whether we're talking about like a big, cortisol and prolonged cortisol increase, or we talk about smaller kind of bouts of stress, for example. Next slide. Hormones can also talk to the immune system. And something that, I heard that I kind of like to think about is that, the hormones in the nervous system can be like close friends. They like to talk to each other. The nervous system tends to tell hormones sometimes what to do, but in short, electrical signals, and that goes fast, kind of like sending a text to someone. And hormones can influence back the nervous system, in a way that's slower because they send their message through the blood. So it's like sending letters, but they still talk to one another, and they try to work in concert to keep our brains functioning as well as it can. So for instance, estrogen, to give an example, is really a hormone that has been shown to influence the formation of new brain connections, supporting learning and memory, regulating our mood. Progesterone can have a very calming effect on the brain and promote sleep, for example. And different hormones can also drive what we call neuroplasticity, which is the ability of our brains to form new connections, to learn new pathways, to maintain function. Next slide. So now we're going to dive a little bit deeper. We've kind of broken this talk in different parts. We're going to talk first about thyroid hormones, then we're going to talk about sex hormone in women, then we're going to talk about sex hormones in men, and then I wanted to add a little piece about cortisol because it's kind of a hot topic, and I can see that a lot of you are interested in this topic. So let's start with thyroid hormones. And your thyroid is a gland that's at the base of the neck that produces different types of thyroid hormone. The one that we know is T3 and T4 that can, circulate in the body and affect many different cells and organs. It is involved in a lot of different functions. Regulate how your body uses calories that you ingest, the energy, and that can affect your ability to lose weight or gain weight. It can also impact your heart rate, slowing it down or speeding it up. It can affect body temperature. It can affect also how your digestive tract and how the speed at which the food moves through your digestive tract, how your muscle contracts and control skin and bone, by controlling how your body replaces cells that die, like skin cells, for example. So it's a very important, those are very important hormones in the body. And there, next slide, things that we know about how, the thyroid can sometimes be dysfunctional in people with MS. And it seems that hypothyroidism or low thyroid hormone levels, it tends to be more common in people with MS, particularly women, and that can play a role in fatigue. So when you have low thyroid hormones, you tend to be more tired, you tend to be more slow, brain fog is, important. You can to also be more depressed, constipated. So everything kind of slows down. And a reason why hypothyroidism tends to be more common in people with MS is because hypothyroidism is often caused by an autoimmune disease, and that can be frequently associated with MS. Thyroid, we know more about how thyroid hormones can play a role in MS, also because it's been shown to be essential for the repair of myelin. So we don't know that yet, but it's possible that people who don't have enough thyroid hormone could have more difficulties repairing and recovering after relapses. For now, the knowledge that we have tends to be more from animal models or from just other types of study, not necessarily human studies, but we can hypothesize that it could play a role in human myelin repair. So it's important to pay attention to thyroid hormones. We also know that some MS treatments can trigger or worsen thyroid dysfunction. So this was especially shown with interferon. So some of you that may still be on injectable medications, it's important to monitor thyroid function with those treatments. Lemtrada is also a treatment that has been frequently associated with autoimmune thyroiditis. So autoimmune inflammation of the thyroid that can cause hypo or hyperthyroidism. Next slide. So what you can do, so, for me as a neurologist, I tend to, often ask questions, to my patients about fatigue and brain fog. And definitely if you notice like a sudden worsening in your fatigue, unexplained weight gain or, weight loss, for example, or if you notice your heart rate being either too slower than usual or faster than usual, or you become suddenly intolerant to cold, for example, like you have to be covered up all the time, it's, those are kind of symptoms that could lead to your doctor to want to check your thyroid. And you can ask them, like, should I be tested or screened? The test that we usually order is called TSH, and that can help screen for thyroid issues in the body. If you're taking a treatment like interferons or, particularly Lemtrada, it's really important to monitor the thyroid. Usually with interferon, we see sometimes some dysfunction, particularly in the first year after initiating treatment. So during that time, it's important to look at the thyroid, the TSH, more regularly. With Lemtrada, it's mandatory to do it every 3 months as part of what we call the REMS program, so the risk management program associated with Lemtrada. Something that I wanted to also add about thyroid function is that people who tend to have not low thyroid hormones but high thyroid hormones for a long time can have a lot of bone turnover, and that can lead to loss of bone tissue, what we call osteoporosis. So if you know that you've suffered from hyperthyroidism, or if you had hypo but you were overtreated for a long time, then it can be important to check whether you have osteoporosis. Next slide. Now I'm going to give it to Alex to talk to us a little bit about a hot topic for you guys, which is sex hormones in women. And men, stay tuned because we're going to talk about y'all pretty soon.
Awesome. Thank you, Leora, and thank you for the great discussion on hormones. I think it's important to talk about thyroid hormones, to talk about all the other hormones in your body, because when we think about hormones, I think we naturally kind of think sex hormones. So great questions in the chat, by the way. I think a lot of these will be answered by the female and male reproductive hormones discussion. So certainly we'll dive into these when we conclude our discussion and answer anything that hasn't been already addressed. So first to discuss, I think this graphic is really important. So this discusses sex hormones across the lifespan. In the blue, you see the testosterone of males and the estradiol or estrogen in males. and the testosterone and estrogen in females. So both sexes have both hormones, clearly. And you can see this kind of natural trajectory of how we have this acute spike here in puberty, right after birth. Of course, we have this acute spike, but really notably after puberty for both the testosterone in males and then estrogen in females. Again, that's what differentiates our sex and our sex organs at that time. But even more notable, I think it's interesting to see here how when you hit the age of 50, 55, when we start to have these perimenopause or menopause conversations, the testosterone in males just kind of generally declines. And you see this really sharp decrease in estrogen in females. So we'll talk a little bit more about this later, but I think it's important to note just the differences in these sex hormones here. And puberty in MS, I think this is something that isn't often talked about. We think of MS as a disease that only affects, young adults, but certainly our sex hormones play a role in MS. Puberty, the surge in sex hormones, primarily, as we addressed earlier, primarily testosterone in males and estrogen in females. They have different effects on the immune system. It's a very nuanced conversation. But in general, estrogen amplifies immune responses, whereas testosterone exerts protective benefits. Not often seen, but can happen. MS can start in childhood and is affected by puberty. Puberty is associated with a marked increase in MS risk, especially in girls. Prior to puberty, boys and girls are equally as affected by MS. So interesting when you think about the impact of these sex hormones. After puberty, MS becomes more prevalent in girls. And we do see a peak in relapse rate. So girls experience a distinct peak in relapse rate around the time of their first period. Boys have lower relapse rates and less pronounced changes across puberty. I see a lot of questions about disease-modifying therapies and thyroid that we can jump into here in a bit. We'll go to the next slide. The menstrual cycle in MS. So in clinical practice, this is something I hear of often. So I often have patients that come to me and they have various worsening symptoms at certain times in their menstrual cycle. It can be premenstrual cycle, it can be in the middle. There's no particular time that is associated with a worsening of these symptoms. There isn't known to be a distinct increased risk at a certain time in your menstrual cycle, but certainly a fluctuation of symptoms can happen, especially in the premenstrual. That's typically what we hear in the premenstrual phase of their cycle. These transient symptoms, aggravations typically occur just before the onset of menstruation. They can include increased motor, sensory, coordination, vision, or even sphincter symptoms, meaning worsening of bowel or bladder symptoms at baseline. One thing I think is key to note that this can include brain fog. So changes in your hormones alone, let alone if you have brain fog as a MS symptom, can cause some fluctuations in your cognition and your perception of your brain fog symptoms. So it's important to know that. I think it's also important, and I tell my patients who come to me that say, I just have right before my menstrual cycle, I have just this acute worsening in symptoms. I think it's important to track. So whether you're writing it in a journal, whether you're putting it in your iPhone in an app, there are like menstrual, period trackers that you could even track your MS symptoms in. So it's important that you take these symptoms, you track them, you show them to your neurologist, you're showing them to your OBGYN, and having a conversation between the two so that we can kind of get some predictability and address your symptoms that way. Fertility and MS, a very hot topic. And I think the key take-home point here is that multiple sclerosis, there's been plenty of data to support that multiple sclerosis does not directly impair fertility in most men and women. And by directly, it means that the disease does not impair the fertility. So the ovarian reserve and the sperm parameters are preserved. Secondarily, fertility rates in women with MS are lower, and that's due to a couple of reasons secondary to MS. So things like sexual dysfunction, depression, fatigue, physical disability, psychosocial impact of a chronic disease. And the one that I really want to, have be kind of a discussion point is the tendency to delay childbearing due to concerns about treatment. in a nutshell, we often tell our patients with MS that you should be treated as a childbearing woman just the same as anyone else, that MS should not be a discussion in your journey or preclude you from exploring childbearing possibilities, that as far as fertility goes, you have the same chances as any other female. Hormonal contraception considerations. Again, a hot topic, especially when it comes to managing symptoms, premenstrual symptoms, or worsening of those symptoms. So there's several different oral contraceptive or hormonal contraception options. I do not directly counsel on these, and I don't know a lot of attending neurologists or neurology APPs that do specifically give guidance on hormonal contraception. So it's definitely the intricacies of which hormonal contraception to go on is a worthwhile discussion with your OBGYN. But there's several different formularies, combined hormonal contraception, so that uses estrogen and progestin. These are safe to use with MS, may be associated with a milder course. Progestin only, so suitable for those with contraindications to estrogen. There are patients, not because of MS, but for other reasons have a contraindication to estrogen. So again, this is a conversation we need to be having with your OBGYN. They're considered safe, but there's less MS-specific effect data that's been studied here. And again, this is a worthwhile discussion and consideration for patients that are looking at contraception because taking hormonal contraception can stabilize some symptom fluctuations based on when you have it. How you take the medication can be directly linked to improved cycle predictability. And there's a little caveat that more research is needed to understand if hormonal contraceptions have a beneficial effect on the actual disease course. So we're talking mostly about symptom management here, but I think in terms of the actual disease course and how MS and neuroinflammation is affected, we just need more data. Some key risks here that are important to discuss. So, of course, with any estrogen-containing product, there is an increased risk of blood clots. That's kind of a blanket risk. And that most disease, asterisks here, most disease-modifying therapies for MS do not interfere with contraception.
Yeah, and something to say about the blood clots, Alex, is that, it's important, particularly for those of you who are have mobility limitations, because for instance, using a wheelchair, not being able to walk regularly, can in and of itself increase the risk of blood clots. So it's really important, particularly important to take that in consideration if you have some mobility limitations.
Yeah, excellent point. Thank you for jumping in on that. That's excellent. All right, pregnancy and MS. I get this question all of the time. I hear various stories of patients that have had relapses after pregnancy or first discovered that they had MS because their first flare was after pregnancy and delivery. So I think this graphic really explains it very clearly. So in kind of a nutshell, pregnancy and MS, the risk of relapse starts to decrease significantly in pregnancy. So there's kind of like this protective window around pregnancy. Not with everyone, but generally we especially see this decrease in risk of relapse around the second and third trimesters. There's some data out there to suggest that the protective, kind of decreased risk of relapse in the third trimester is as effective as our most effective DMT. So I think that's really promising. But really the take home here is that the risk after delivery starts to increase. So your immune system, while kind of like batted down during pregnancy so it doesn't reject the fetus, kind of comes back in its full force, and the risk of relapse starts to rise again at approximately 4 to 6 weeks. So that's really when I start to counsel my patients that we need to have a plan the whole way through. We need to be having a plan on how to, address pregnancy, how to ease into pregnancy, what to do during pregnancy, and certainly have a plan after you deliver so that we can have a seamless transition back onto disease-modifying therapy when that should occur. The risk of relapse, and this is really part of, the key part of the discussion, starts to have an uptick at 4 to 6 weeks for most patients. And then as you can see in the graphic, which is well illustrated, it really starts to hit its peak at 3 to 6 months. So that first trimester after pregnancy, the risk of relapse is actually higher than your baseline risk of disease. So it really kind of ramps up, as you can see. So really important to have a conversation, have a plan with your OBGYN or maternal fetal medicine, be a part of this discussion so that we can keep you disease free throughout the process. Some more DMT, disease modifying therapy considerations here. If you have MS, again, I will say this, talk early and often with your neurologist about becoming pregnant. If you already are, it's important to talk to your neurologist. Anytime you are planning a pregnancy and you have MS, I certainly would want to consult with your neurologist or OBGYN, make sure that they're in good communication, that they're on the same page. Most disease modifying therapies are not safe during pregnancy. Again, kind of, an asterisk point here. They need to be stopped ahead of time, but there's some graceful planning that can be done with a lot of these disease modifying therapies, specifically the B cell therapies, where you can stop ahead of time, but still get some coverage from MS through the first trimester, which still has a decreased risk, but some risk of relapse. So there's kind of some 2-for-1 that you can plan out here if doing it gracefully with your neurologist and OBGYN. Some treatment, this is again, a really important point. Some treatments may be dangerous to stop abruptly, so planning ahead is important. Treatments like Tysabri or Gilenya or any of the S1Ps can cause a rebound of disease activity. So if you stop abruptly, your cells, your B and your T cells will enter your bloodstream and your MS will get a hold of them and have the potential to have new disease activity. So there's a way by which we would like to transition you off of them and or switch you to another disease modifying therapy prior to conception. And we do this often. This is, standard practice for your neuroimmunologist. So please talk to your provider about this prior to conception if you're on one of these drugs. And due to the risk of relapse in the postpartum period, we alluded to this earlier, we really recommend that you resume your disease-modifying therapies between week 4 to 6 after delivery. And there's been a lot of data recently about the B cell therapies specifically that prove their safety with breastfeeding. So it's always a hot topic in my clinic. Can I breastfeed if I'm on XYZ medication? Please continue to ask those. We can discuss the data. We can have these conversations with your pediatricians, your OBGYNs. B cells are generally considered safe and compatible with breastfeeding.
Yeah, I wanted to add because I saw a question in the chat or a comment in the chat that says, my doctor said to have Ocrevus as soon after delivery. That is, there's some nuance to that. When so Ocrevus is one of those B cell therapy that has been proven to be safe during with breastfeeding. The caveat is that when women breastfeed initially, they produce what is called the colostrum. This is the early milk. It's not the mature milk. It's the early milk that contains a lot of antibodies. And we know that, Ocrevus being an antibody can be excreted or, transferred through the colostrum. So generally, when I counsel patients, who, for instance, are on Ocrevus or another B cell therapy, I want them to resume their treatment early after pregnancy, but not too early. So generally, the first 2 weeks, women can still produce colostrum. So it's not the right time. So usually I tell them, wait the first 2 weeks and try to have it done by week 6. Generally the sweet spot for women is usually week 4. By that time, they kind of feel a little bit more rested. They're ready to just have their infusion, and that helps us prevent new relapses in the postpartum because we know that they tend to happen during that, those first 3 months. So, I would say, we want to get it done at the latest by week 6. Usually I tell my patients, between week 2 and 4 is great, but not right after you deliver. Like, it's not like you're going to get it as soon as you're back home, just because the colostrum is a little different from the mature milk that is produced after week 2.
Thank you for jumping in on that, Leora. And as far as timing, I think it begs saying that these aren't like hard and fast rules. Like, it's not saying that if you miss week
And
six,
just
like,
just a word because I say somebody said about pumping
yeah,
for infusion. There's no reason to pump. If you receive Ocrevus and there's no reason to pump your milk or and discard the milk. There's really just extremely small, minimal transfer in the breast milk, so the milk is safe for the baby to ingest even right after your infusion.
yeah, yeah, thank you. Okay, and then next slide. So the ever hot topic that I hear about in my clinic, I see on all of the chats, and I think is ever in vogue in terms of data and what we're looking at for MS and how hormones affect MS is perimenopause and menopause. So just some kind of key tenets and descriptors here. Naturally, menopause occurs 12 months after a person has their last menstrual period, so you have to be period free for 12 months. That is considered when you're in menopause and is no longer obviously able to become pregnant. Now, typically, this happens between 45 to 50, although this is a range, these may vary, or after the surgical removal of the ovaries and a uterus. So this is a surgical menopause or obviously a hysterectomy. And then perimenopause, which is also a range. This can be a fluctuation of symptoms that you can see over here. So hot flashes, night sweats, bone loss, adverse mood. You can read through these. We'll go over the overlaps of these symptoms and MS symptoms here in a bit. But this is, again, really a range. This can happen. I want to caution you, this can happen. We see it in patients in their late 30s and can last, well into patients, in their early 60s, late 50s. So it's a range and it's different for everyone.
Yeah, and yes, to answer in the chat, the red line reflects the symptoms. So you see that, your symptoms will start, the symptoms of menopause will start in that pre and perimenopause period, you
Mm-hmm.
know, and even when people still have their periods. So this
Mm-hmm.
is what confuses a lot of folks. In perimenopause, women still have periods, so they don't think necessarily something is wrong. But their periods can be a little bit different. Their bleeding can change, and
Mm-hmm.
but I think the message, as Alex said, is really, sometimes we see some women experiencing early symptoms of perimenopause, even in their late 30s, and it's important to just kind of be attuned to that these changes take time, and it may be years of experiencing perimenopausal changes.
Sure. Yeah, excellent point. And also like this red line that you see here isn't always as linear as that. You see patients that come and they present with perimenopausal symptoms. They may have these, transient symptoms. They're having regular periods, and then poof, they go away, and then 5 years later, poof, they're back. So, I think everyone's perimenopause journey is a little bit different. Again, I recommend tracking symptoms, being contact with your gynecologist or OBGYN. And certainly, if you think your MS symptoms are affected by these changes, we need to be having this discussion with your neurologist. You can go to next slide. So I love this slide. I was telling Dr. Freeman earlier today, if I could print this and like put it up in my clinic room, I would, because I think it's something that we as a community are starting to understand more. We're really looking at it and understanding it. But perimenopause and menopause symptoms and how they overlap with MS symptoms. So I frequently see this, and I know Dr. Freeman has a story here in a bit, but I frequently see this as kind of the classic tale of like, I have a 45-year-old female. She comes to me. She's been stable on disease-modifying therapy, and her MRIs have been stable. She's on a high-efficacy therapy, and she comes to me and she's like, Alex, I think I'm having a flare. My sleep patterns are disrupted. Like I have temperature dysregulation. My neuropathy is worse. I'm extremely fatigued. I have brain fog. Like I think my MS is flaring. And if I can prove, if I know that she's stable and if I can prove that MS isn't the case, oftentimes I start to ask the question of could this be perimenopause, right? Because there's so many overlaps in symptoms like sleep disturbance, mood changes, urinary frequency or sexual dysfunction, cognitive symptoms, brain fog, neuropathic pain, cramping, fatigue, Again, temperature dysregulation. Both of these can look, or all of these can walk and talk a lot like MS symptoms. And certainly if you're having these symptoms, even if they're from perimenopause or menopause, they can be kind of a driver to worsen your MS symptoms. So hard to, sometimes tease apart, but I think it's important to understand that they frequently overlap. So can menopause worsen MS symptoms? Many people with MS are sensitive to heat. We know this. This is a phenomenon called Uthoff's phenomenon. So when MS patients are exposed to heat, they can have worsening of any of their presenting or baseline symptoms, whether it's vision, neuropathy, weakness, imbalance. And there was a survey that came out with women with MS, and I think it was pretty overwhelmingly reported that hot flashes made their existing MS symptoms worse until they cooled off again. And so I think Dr. Freeman has a really interesting story and a great insightful
Yeah.
story.
Yeah, it was really interesting. So I had one of my, beloved patients that came to the clinic, and and she's been struggling. She's has mobility issues at baseline, and she's in her 40s and late 40s, and she came to me and she's like, I just feel like my MS is worsening, and I don't know, I don't know what to do every day. I the only thing that makes me feel better is taking ibuprofen. And I'm like, well, are you in pain? And she's like, no, I have no pain. I was like, but why do you take ibuprofen? And she's tells me, well, because it makes me feel better. And so I kind of, in my head, I was like, why would it make her feel better? And then it dawned on me that, you know, that maybe, because ibuprofen sometimes can help reduce fevers and help reduce body temperature, so I asked her, I was like, do you feel kind of hotter than usual? She's like, yes, I feel hotter than usual. And well, I was like, this may be why you're experiencing these changes. And I was like, when was the day of, do you still have your cycle? When was the day of your last period? Because she didn't volunteer this information. She was like, well, now that you ask me, I don't think I've had a period in the last year. And I was like, well, sounds to me like you're having kind of this menopausal kind of elevation in body temperature that down, and that affects the nerve conduction in MS, just like any other heat, that's the Texas heat, can affect that as well. And so, teasing this out, we're able to be like, okay, maybe we need to manage the menopause aspect of it to, instead of just taking a bunch of ibuprofen every day, to be able to improve your symptoms. And so, we sent her and referred her to an OBGYN and tried to make some changes through kind of pharmacological treatments.
Yeah. Excellent point. And really, how I counsel my patients, and, maybe Dr. Freeman, you want to jump in, because even if there is this question about HRT, I tell patients, have a conversation with your OBGYN, with your gynecologist. From an MS standpoint, HRT is not contraindicated. So if it's otherwise not contraindicated, that you are determined with your OBGYN, then we are generally, and this is kind of an, overarching statement, we're generally okay with you taking HRT.
Yeah, and I think you have a slide about that, in a little bit.
Mm-hmm.
Mhm.
Mm-hmm. I was just addressing, there's a couple questions here. So this is also a hot topic. And I think there's more that needs to be understood. But the question becomes is, can MS impact the course of MS? This is a really interesting study. So there's a cohort study of 184 women with MS that they followed for a good amount of time, probably, through the duration of their menopause transition and perimenopausal transition. And what they found was that menopause was associated with worsening clinical scores, encompassing cognition, ambulation, upper extremity function, and worsening of NFL. So, what is NFL? It's neurofilament light. It's a biomarker that we are increasingly looking at in MS patients that can tell us a lot about nerve cell injury. I think that there's a lot more that needs to be done in terms of the data and research. There's really some uncertainty about what exactly happens after menopause in the course of MS. But I think it's important to note that there's these cohort studies that do show some worsening functions. So more to be had in the data, but looking at that, there's several studies that are looking at this right now. And really in the conversation, I think it becomes a complex conversation even in these studies and then the data, because there's and it's hard to tease out what's what in terms of the course of MS. This is a great graphic that really takes some dissecting. So you'll get the webinar slides tomorrow, but I would really look at this. So you talk about MS, its intersectionality between and its overlay with, are we seeing more axonal injury? We see this decline in cognition, mobility, dexterity. Is this worsened also, by natural changing in your epigenetics or your genetics, modifiable risk factors like smoking and BMI. And then there's some also MS variables, right? MS, there are several different phenotypes or different types of MS. Everyone has a different MS history. Have you had recent relapses? What therapies have you been on? How stable has your MS been over time? What is your disease duration? So there's some distinct differences with patients that are diagnosed early versus patients that are diagnosed post-menopausal or later in life in terms of disease course. And then, of course, we have to think about comorbidities. So, things like cardiovascular risk factors, renal risk factors, diabetes. How are these all interplaying in your systemic inflammatory environment, how your disease is presenting, and just overall how you're doing in terms of quality of life? HRT, I think the most hot topic here. So HRT, there's some data to suggest that hormone replacement therapy may have some neuroprotective effects. Estrogen may reduce inflammation and support CNS repair. So not only does it improve symptoms such as mood, sleep, cognition, and quality of life in postmenopausal women, there is some data to suggest that it actually has a role in reducing inflammation. So risks, I think this is an important topic and something that should be more closely discussed with your OBGYN. The risk-benefit ratio of HRT varies on age and individual factors. So for women over 60 or within 10 years of menopause, for vasomotor symptoms and bone health generally outweigh the risks. For women initiating HRT more than 10 to 20 years from menopause, the risks may be higher. There's a couple of studies recently talking about dementia risks. I won't go too much into that, but generally, you want to think about timing and risks to consider, we've talked about this, but includes bone clots, particularly with women with limited mobility, so wheelchair and limited mobility patients. So again, all of these discussions with HRT needs to be individualized, discussed with both your neurologist and your OBGYN.
Yeah, and it's important. There's a lot of questions on the chat, and maybe we can take a little bit of a minute, since we're kind of coming, we're probably going to come short on time, but wanted to kind of address a few questions. There was some initial data, initial concern about HRT in women in studies that were done about 20 years ago, but the data is really changing. And what we really see, whether we're looking at the impact of HRT on, cognition, for example, or cancer risk, is that, timing of HRT is essential, and then targeting kind of women who are younger or earlier in menopause can help limit some of the risks and really enhance the benefits. And that's particularly, there was some initial concern that HRT could promote a risk of dementia, for example. Now we know that HRT done earlier in the right way, can actually decrease somewhat the risk of dementia, but doing too late in life could actually enhance it. So there's kind of a timing associated with hormone replacement therapy that really needs to be, and decision that really, really need to be individualized. The risk of blood clots is still a risk that's real with all these hormonal therapy. And again, kind of like thinking about women of limited mobility, it's really important to take that into consideration. I saw a question from Kathy, I believe, about hormone health in women above the age of 65, and we don't have a specific questions about this, but this is really an interesting question, and because as you see, like the menopause is a relatively kind of, the decline is relatively sharp, so then you're like, okay, well, I go through that, then I'm better. But the truth is that what happens after 65 is that there's a lot of hormones that tend to kind of be, kind of slower, and things tend to in concert become a little bit a little bit sluggish. It's not just about estrogen that continue to be kind of decreased in its production, but there's also kind of also something we haven't talked about that happens also in women, which is a decline in testosterone that contributes to the reduced muscle mass of women, reduce of strength, reduce of libido. There's also some issues with thyroid become that can become more sluggish with age. So I find that once women kind of go through this kind of really sharp period, sharp decline associated with menopause, but we enter more of the kind of everything kind of slow kind of period after the age of 65. It's not just, we need not just to look at just sex hormone, we need to take everything in consideration together. We can also see a lot of comorbidities that happen at that age that can really influence functioning. For instance, thinking about another hormone we're not really talking about specifically today, which is insulin. We see a lot of insulin resistance happen with older age and after the age of 65, and we know that this can play a role in MS as well. So it's not to say that after 60, 65, everything's kind of great, but it's almost a different conversation that needs to be even more holistic. It's not just addressing menopause in a vacuum, it's really addressing the whole person and all these different hormones that together can kind of slow down and play a role. So I hope this answered your questions, Kathy. Just wanted to really acknowledge this because I feel for you all, my our patients that are above the age of 65 and are trying to live their best lives. So it's tough.
All right, and I'll hit on my last slide here. These are just kind of the high points for recommendations for perimenopausal women. Speak to your doctor about your symptoms, understand, and by doctor we mean your OBGYN, your gynecologist, and your neurologist to understand if they are due to MS or menopause and or both. Engage in beneficial lifestyle changes. So no secret weapon here, but sleep, hygiene, regular exercise, mindfulness. I will add mental health to this. I think that the perimenopause and menopausal time can be tough for women to navigate, and men for andropause. So I think it's key to take care of yourself during this time. Discuss treatment options that can help. So things like hot flash medication. There's there's a medication specifically that is non-hormonal for hot flashes that you can talk to your OBGYN about. You can do things like pelvic floor therapy and pharmacologic approaches like HRT, not contraindicated for women with MS and is often beneficial for patients with MS that are perimenopausal. This I think is a blanket for all of our MS patients. At least this is the way that I treat it, especially our high risk fall patients, that I really try to stress the importance of screening tests for osteoporosis. Because the last thing that we want as clinicians is to see a fall with a fracture.
And just one last word also, because I saw a question about urinary symptoms. For example, just wanted to say a quick word that some women do not necessarily take hormone replacement therapy by mouth, but may use some vaginal estrogen to help with the trophicity. What happens with the menopausal period is that the vaginal wall becomes very thin, and that can worsen urinary symptoms. And so sometimes, you may not have use for just full HRT, but using some estrogen locally, topically, can do wonders for bladder function in women with MS. So something to keep in mind, as well as PT, pelvic floor PT, because this is definitely something that we see that gets worse in our patients.
Awesome. And then I will hand it over to Dr. Freeman to discuss considerations for MS.
Yeah, we didn't want our men to feel left out, so we'll go to the next slide. As we talked about, if you follow the solid red line, women experience kind of a sharp decline, with menopause and their sex hormones. Men tend to have a slower kind of slope of testosterone, but that doesn't mean that they're not experiencing, changes as they age. So what we name andropause is this gradual drop in testosterone that happens to men as part of natural aging, and that can be associated, as we'll see, to some symptoms. So let's do a quick dive into how testosterone can impact the brain. Testosterone can play a role in brain development. We see it in, as we age and through puberty, but it has a role in neuroprotection, supporting cognitive performance, supporting mood, modulating pain perception. It can influence some areas of the brain that are involved in memory and overall executive functioning. And it also seems to play a role in how our brain regions talk to one another through what we call neurotransmitters like dopamine or serotonin, and that plays a huge role in mood. Important hormone here. And even though men have a large amount of testosterone, us women also have some, so this kind of also applies to us as testosterone levels tend to decrease with age. Next slide, you'll recognize this is a very similar slide to what we saw in menopause, is that, we see some symptoms that, and again, there's a typo here, but the symptoms of MS and andropause frequently overlap. And it's hard to know sometimes which is which. We can see sleep disturbances, mood changes, sexual dysfunction, cognitive changes, reduced muscle mass and muscle strength, and then also fatigue. Important to keep in mind for our older men that this can play a role in how they feel. Next slide. There is not a lot of data. I would say that if we think that menopause doesn't have a lot of data, then andropause has even less. There's very, very little information about how andropause, the decline of testosterone influenced the disease. It seems there's just small studies, so there's little asterisks next to everything that I'm saying on this slide, but there's small studies that seem to show that lower testosterone are seen in subsets of men that have greater disability or worse cognitive performance, so highlighting that testosterone may be needed to maintain some of these functions. We have some data also from animals that seem to link androgen or testosterone to remyelination and the integrity of nerve cells. So it is possible that andropause, as the testosterone declines, could contribute to disease worsening in humans. Next slide. So there's a lot of talks about testosterone replacement therapy in the general population. We see even younger men, going on TRT, just to, explain that we have guidelines in the general populations, not so much in people with MS. But generally, the recommendation is only for men who have low serum testosterone, so blood testosterone levels that are low, associated with symptoms. So we don't treat just a number, we treat the numbers and associated with the symptoms. So it's not something that people, should be doing just for anti-aging and living forever. This is really something that we want to do if it's going to have a symptomatic benefit. Keeping in mind that testosterone, especially if it's done in a way that is super therapeutic, meaning that we're overcompensating the testosterone, can lead to some complication, heart attack, stroke, blood clots, but also a prostate enlargement, which can be associated with worsening of bladder symptoms, which in MS is, would not be really fun. And also for younger men who may be thinking about doing TRT, just always remembering that it can be associated with infertility. There was some very pilot trials that have tested testosterone in men with MS, one that looked at 10 men that were treated with testosterone, and they did experience some cognitive improvement and some slowing of brain atrophy. Obviously, we need more data. This is just anecdotal at this time. So we need to learn more, and I would add that really both men, we need to learn more about testosterone in both men and women. Next slide. Finally, I wanted to talk about cortisol because I think this is something that I'm hearing more and more about. And when we talk about cortisol, really people tend to think that cortisol is the stress hormone. This is like the hormone that is produced during more than that. Testosterone, cortisol is produced by the adrenal gland, but it's really part of an entire system, an axis, where we have a gland called the hypothalamus that produce a hormone that communicates with the pituitary gland that produces another transmitter that communicates with the adrenal glands that it produces cortisol. So this entire axis, we call it the HPA axis for hypothalamus, pituitary, adrenal. And I like to think about this, the cortisol, as not just being a stress hormone, but really thinking about it as an energy hormone. It plays a role in wakefulness, and it can, in people, with MS, can, contribute, to fatigue. It also has a role on the immune system where it can, especially in, reduce inflammation, for example. So it can help keep the immune system in balance, particularly in people who don't have any dysregulation of that system. Next slide. Cortisol, when we talk about cortisol, it's not just like one level that stays stable all the time. Cortisol actually follows a pattern throughout the day. So it starts raising during the end of the night so that it's at its peak early morning so that you can wake up and actually feel awake. And then it tends to decrease slowly and increase with each meal. So during lunchtime, during dinner time, and then it's at its lowest at the first part of the night before re-increasing again the next morning. And having a good cycle of cortisol is what's important. It's not having low cortisol that's important, it's having a good cycle of cortisol. We want cortisol high in the morning, we want it low at night. Next slide. So there's been some studies, but again, we know very little about this in MS, but there's been some study that have found that some people with MS can have a hyperactivation of the HPA axis. Hard to know exactly what this means in terms of, of the symptom consequences for these patients. We don't know that much, but this means that these patients can have elevated cortisol level, and we don't know what is the chicken, what is the egg. Is MS causing this, or is this contributing to MS? It's really hard to know. What's we see is that in spite of having high cortisol, their tissue doesn't respond well to cortisol. So they have this kind of resistance to cortisol that doesn't respond, because normally when you have high cortisol, the tissue kind of responds to try to decrease it. But here we see continuous kind of elevation in some of these patients. But what I find most important is the studies that show that people that have MS tend to have abnormal cortisol rhythm. And for me, that's like something that's really actionable. If you don't have cortisol that peak in the morning, that decrease at night, then you're going to have impaired wakefulness, you're going to have more fatigue, and it's going to be really, really difficult to respond to stress, and that can cause a lot more symptoms with MS. So I wanted to give kind of some advice what people can do to try to promote healthy cycle of cortisol through the day. One is getting sunlight in the morning, and that's really tough, especially for those of you who live up north. But getting sunlight as soon as you wake up, if you can. So what can you do if you wake up and it's dark out? Then you can use one of those sun lamps that have like 10,000 lux lamps that are, you can buy off of Amazon. That can help kind of give you kind of this boost of sunlight early in the day. So ideally before 10 a.m., but even as soon as you wake up, kind of using either one of these sun lamps or direct sunlight. You want sunlight in your eyes, okay? Then you want quality sleep, because you want, again, to have low stress level at night. You want to have good sleep hygiene so that you promote kind of the depletion of cortisol at bedtime. So sticking to a consistent bedtime, reducing screen time before bed, making your bedroom cool, 65 degrees, quiet. This is really important. Exercise can, we tend to think like, oh, exercise is going to just boost my cortisol level. Well, it can play a role in that, especially early in the day, in having that healthy cortisol at the beginning of the day. And in general, it just promotes brain health. What we see is that if you do the same exercise every day, it tends to not necessarily impact your cortisol level, even if it's late in the day. But in general, I recommend regular exercise, and exercise that's very active, tend to do it earlier in the day. Another one is using stress management strategy. I'm a big fan of, yoga, meditation, Deep breathing exercises can be really important, especially if you like me and you can't meditate and clear your mind. Focus on breathing exercises. For some of us, that can take the, that can be prayer or guided relaxation. But that's also been shown to be beneficial in reducing stress and lowering cortisol level in people with MS. Then balancing blood sugar. Interestingly, you saw that cortisol increases with so big spikes in blood sugar can really trigger cortisol surges. So really trying to eat balanced meal, eating fiber and healthy fats along with the carbohydrates, avoiding sugar and highly processed food is really important. And then finally, for some people, especially those who suffer from anxiety, depression, that can be linked to this kind of dysregulation of this HPA axis, a therapy can be really good, and they can give you strategies to help manage the stress as well. So I thought this would be great kind of tips to kind of close our webinar because it kind of applies to all of our, hormonal health topic today. So if anything you need to remember is kind of those last two slides, just how do you take care of yourself? And for those of you who struggle with finding providers to help manage your hormonal issues, I am with you. It's a struggle for us as providers as well. So start with the things that you can do that you can feel empowered to do. But also if your primary care doctor is not helping you manage your hormonal issue, if your OBGYN is not helpful, find another one if you can. There's a lot of online providers as well. Just seek help as you can. Ask your neurologist. They may not be the ones who manage your hormones, but they may have some preferred providers. I know in our clinic, we try to find the best providers we can find in our community for our patients. So also doctor as well if they have any recommendations. And if you find the pearl, the provider who's helping you with your hormones, go tell your neurologist, because then they can pass that information to the rest of their patients. This has me anytime I have a patient who rave about another provider, I'm like, please tell me, I'm taking notes. I need to know who you're seeing, So if you find some great people in your community, pass it forward, and telling your neurologist whom you found is important. Anyway, we didn't get. I hope we got to a lot of questions while going through this webinar, and I hope all of you feel that this was helpful.
You definitely answered a lot of questions live, I think, tonight throughout the presentation. And I'm going to drop this in the chat again. Please email us at info@cando-ms.org. If we didn't get to your questions tonight, we would still love to answer them. I can get them to Alex and Leora and other providers that can help answer anything that's specific. So again, we'd love to still be able to help you and answer questions this evening. Huge thank you to Alex and Leora. Wow, we covered a lot of content. I'm so glad that we have this recorded. This will be available to all the participants tomorrow. We should have it available around this time tomorrow evening. We'll also have a copy of the presentation slides, and all of that will be sent out in a follow-up email to all of you. So thank you to Leora and Alex for sharing all your knowledge. Thank you to all of our participants for tuning in. And one last time, I do want to thank our sponsors because we would not be here tonight if we didn't have their support as well. So thank you everyone for being here, and I hope you all have a great evening.